Now let's discuss nephrotic syndrome, which is very different from nephritic syndrome. These two are not the same, even though they sound very similar and they have just one letter difference. But nephrotic syndrome is not an inflammatory condition. I'll repeat that again. It's not an inflammatory condition. Now, what does that mean? There's usually no fever and no hematuria. Instead, there is massive proteinuria greater than 3.5 grams per day, hyperlipidemia, severe clinical edema, and increased risk for thromboembolism due to urination of antithrombin 3, and increased risk of infection due to urination of immunoglobulins. The first nephrotic syndrome that we're going to discuss is focal segmental glomerulosclerosis, also known as FSGS. Just looking at the name, what percentage of the glomeruli will be involved? Well, we can tell that there will be less than 50% because it is focal, and because it is segmental, only parts of the glomeruli are sclerosed, meaning they look scarred. And this is going to be on light microscopy. When we look at immunofluorescence, the IF will be negative because there are no antibodies involved and therefore nothing's detected. And on electron microscopy, the foot processes of the podocytes are effaced, meaning that the normally spaced foot processes with their little grooves between them disappear, and the foot process just looks like one big blob on the outer surface of the glomerulus. And this disease, FSGS, is a common cause of nephrotic syndrome in adults and is the most common glomerular disease in African Americans and Hispanics, and importantly, HIV patients. And here, when we look at the light microscopy image, this is just one glomerulus, but we see that there is segmental sclerosis. Here is an area of sclerosis, but this area looks pretty normal. And then here's another area of sclerosis as well as here. So we see that it's segmental. And if we were to zoom out and look at all the glomeruli, we would see that less than 50% of the glomeruli would be involved. And lastly, there is an inconsistent response to steroids with these patients. So we try the steroids, and sometimes we'll get a response, but sometimes we don't. Next is membranous nephropathy. This one is a bit more complicated. The common histologic findings include capillary and glomerular basement membrane thickening on light microscopy. Notice that this time the glomerulus is completely involved. All of the areas of the glomerulus are thickened. Now, on immunofluorescence, there's going to be a granular pattern due to immune complex deposition. Remember that an immune complex is an antibody and its antigen bound together. And on electron microscopy, we'll get a spike and dome appearance with subepithelial deposits. Membranous nephropathy is the most common cause of nephrotic syndrome in Caucasian adults. Patients may have antibodies, specifically autoantibodies to the phospholipase A2 receptor 1. It can be caused by a number of drugs such as NSAIDs or penicillamine, infections such as hepatitis B virus or hepatitis C virus, and systemic lupus erythematosus and some cancers that create solid tumors. Membranous nephropathy responds poorly to steroids. Now that we've talked about the common causes of nephrotic syndrome in adults, let's talk about minimal change disease, which is the most common cause of nephrotic syndrome in kids. So, will you see anything abnormal on light microscopy? No, the glomeruli are going to look normal, and that's why it's called minimal change disease. On immunofluorescence, it's also going to be normal. You're not going to see anything. But where there is an abnormality is on electron microscopy. And here we'll see foot process effacement. Remember, those foot processes are coming from the podocytes, and they form these little filtration slits. And in minimal change disease, they get effaced, meaning we no longer see the regular repeating filtration slits, but rather just one straight line. Basically, the podocyte has just formed one blob on the surface of the glomerulus, and we no longer have those regular repeating foot processes. And this leads to a disruption of the normal glomerular filtration barrier. And this defect is going to lead directly to the loss of albumin into the urine, which contributes to the patient's symptoms, primarily edema. Now, it usually is triggered by a recent infection, immunization, or some other immune stimulus, and it can be associated with Hodgkin's lymphoma. Typically, these patients have an excellent response to corticosteroids. Next on the list of nephrotic syndromes is amyloidosis. This is a systemic disease process, and the kidney is the most commonly involved organ. Now, on light microscopy, when using the Congo red stain, you will see an apple green birefringence. You see this shiny green stuff here? That's the apple green birefringence. And it is the giveaway for amyloidosis. If you see apple green birefringence on your exam, immediately think amyloidosis. Amyloidosis is associated with chronic conditions such as multiple myeloma, tuberculosis, and rheumatoid arthritis. Next, we have membranoproliferative glomerulonephritis. That's a mouthful, so we're going to refer to it as MPGN. And there's two types of MPGN. Type 1 is marked by subendothelial immune complex deposits. And on light microscopy, you'll see a classic tram track appearance. It's difficult to see on this image, but on your exam, if they want to show you tram track appearance, it'll look very obvious, and you'll just see two glomerular basement membranes split apart from each other rather than one nice thick glomerular basement membrane. Now, type 1 is associated with hepatitis B virus, hepatitis C virus infections, and sometimes can be idiopathic. Type 2, on the other hand, has intramembranous immune complex deposits, and these are called dense deposits. Type 2 is associated with C3 nephritic factor, which stabilizes C3 convertase. And this leads to activation of the complement cascade, leading to decreased levels of C3 in the serum. And so you should look for that in a patient that may possibly have MPGN. If they have decreased C3 levels in the serum, that's a good sign of MPGN. And MPGN is one of the syndromes that can cause both nephritic as well as nephrotic syndrome. So that's important to keep in mind. All right, let's finish up nephrotic syndrome by taking a minute to discuss diabetic glomerulonephropathy. Since diabetes is so common in the US, this is the most common cause of chronic kidney disease and dialysis in this country. It results from high blood glucose leading to non-enzymatic glycosylation of the glomerular basement membrane as well as the efferent arterioles, which just means that glucose molecules start binding to proteins in the basement membrane and efferent arterioles non-enzymatically. And this leads to permanent thickening of the basement membrane and mesangial expansion. And these changes contribute to the pathognomonic finding of diabetic kidney disease, the Chemosteel-Wilson lesion, which is the diffuse pink glomerulus that looks like a nodule. And you see this pink glomerulus here. It's very fluffy looking, very pink, and it looks like a nodule, and it's called the Chemosteel-Wilson lesion. The disease results in increased permeability of the glomerulus as well as constriction of the efferent arterioles, as that efferent arteriole gets narrowed due to the thickening caused by the non-enzymatic glycosylation. And this is going to lead to an increase in the GFR, if you remember from renal physiology. So increases in GFR are going to do what to urine production? They're going to increase urine production in these patients, as well as what's going to increase urine production is all that glucose in the urine that's osmotically pulling water into the urine. And these two reasons are why diabetic patients urinate so much. Now that we've gone through some details about nephrotic syndrome, let's see how prepared we are to answer questions that might come up on your exam. Ready for a flash quiz? Here we go. A 6-year-old boy presents to your office complaining of swollen legs. On exam, he has diffuse edema in both legs. His mother tells you that he had a bad sore throat a few weeks ago. But the doctor gave him a medicine she can't recall, and it went away after a few days. A 24-hour urine test reveals 5.5 grams of protein in the urine. What is the most likely cause of this boy's edema? The answer is minimal change disease, MCD. Now I know what you're thinking. That throat infection sounds a lot like strep throat. So this has to be post-streptococcal glomerulonephritis. But if you just remember the difference between nephritic and nephrotic, you'll see why that can't be the case. First of all, since post-strep GN is nephritic, you would expect to see some fever and hematuria with the edema. But we didn't see that. But more importantly, the patient has proteinuria of 5.5 grams per day, which is more than 3.5 grams per day. So that is the sign that it is more consistent with nephrotic syndrome. Since this is a kid and it's happening after an infection, and we see this high level of proteinuria without hematuria and fever, the most likely cause is minimal change disease.